So this acronym EAST AFNET 4 stands for Early Treatment of Atrial Fibrillation for Stroke Prevention, so that's EAST. And AFNET is the German competence network for atrial fibrillation. It's a research consortium. We now call ourselves an academic research organization that runs investigator-initiated clinical trials that are aimed to change practice. EAST AFNET 4 was the fourth of these. It's probably been the most widely covered. But we are actually currently working on summarizing the results of SMART and OAC AFNET 9. We still have 2 more years to go until we finish NOAA AFNET 6. And it's a very exciting research network that has involved centers and patients in 17 European countries and in the US. And I do think it's a wonderful partner to work with. Almost everyone gets rate control when they are diagnosed with atrial fibrillation, but only 1 in 10, maybe 1 in 8, maybe 1 in 5 gets rhythm control. Now, when you think about it biologically, atrial fibrillation damages the atria, we all know that, and it's not good for us in terms of outcomes. So you would assume that rhythm control therapy should actually be helpful if it can be delivered safely. And that was the starting point for EAST AFNET 4 when we started about, over a decade ago. And we tested early systematic rhythm control therapy compared to usual care in almost 3,000 patients, 2,789 to be precise, with recently diagnosed atrial fibrillation, diagnosed within a year prior to randomization, and at least 2 of the Charts Risk factors. The trial clearly demonstrated that this systematic rhythm control therapy reduced cardiovascular outcomes. The primary outcome was a composite of cardiovascular death, stroke, and hospitalization for heart failure or acute coronary syndrome by 21% compared to usual care. And therefore, the simple conclusion in my view is that patients with recently diagnosed atrial fibrillation should be offered not only anticoagulation and treatment of other cardiovascular conditions, but also rhythm control therapy. We've got a famous German football coach that says, nach dem Spiel ist vor dem Spiel. So at the end of a trial, you always come up with concepts and things that need testing. I do think that we have very solid data that early rhythm control therapy, as it was delivered in EAST AFNET 4, using a combination of safe use of antiarrhythmic drugs and AF ablation that was mainly confined to pulmonary vein isolation, also trying to keep it safe, is effective. And we should implement that in clinical practice. But of course, there are other questions. Can we achieve even better outcomes if we use the most effective treatment for rhythm control? Are there other ways to make rhythm control safer than we achieved in EAST AFNET 4? And I do think we also need to study specific populations. For example, patients with heart failure with preserved ejection fraction, where it's very hard to distinguish whether HFpEF is due to AF or the other way around. Or patients after an acute stroke, who are considered very difficult to treat because of safety concerns, but who also have a high risk of cardiovascular complications. There are still things coming out. At this EHRA meeting, we actually will have a hotline presentation on the effect of sex on early rhythm control. And at the HRS meeting in a month's time, we'll talk about the interaction between comorbidity burden and early rhythm control. And I think we are continuing to learn and to interrogate the data, but I do think we also need new trials that should not take away the main finding from EAST, which is that patients with recently diagnosed atrial fibrillation and cardiovascular conditions benefit from systematic application of rhythm control therapy. We are now offering rhythm control therapy to all patients who fit the inclusion criteria that we see. And I do think that we also have gained more confidence in the safety of rhythm control therapy when we follow the current recommendation of international guidelines. I do think that new data always needs some time to be understood, interrogated, put into context before they change guidelines. The current guidelines do not have a statement that clearly recommends rhythm control therapy outside of symptom control. But then they were written and published before we presented EAST. So I do think that we need to wait for the next iteration of the guidelines to have that included. But I do think it is reasonable, rational, and evidence-based to consider the outcome of EAST and the way rhythm control was delivered in EAST AFNET for our patients treated today.